All right. Good day, everyone, and welcome to another segment of our endocrine system. Today, we're going to be talking about one specific organ here, which is your pancreas. So today's focus is going to mainly focus on diabetes type 1 and diabetes type 2. So the main organ we're going to talk about, your pancreas. So your pancreas, right? So we have to know a little bit about anatomy again. So a little review there is your pancreas is in charge of aids in the digestion of protein, fats, and carbs. But the main thing we're going to talk about today is this function right here. It produces this hormone. I want you to remember that. It is a hormone called insulin. So insulin, the main job of the insulin is to regulate blood sugar, mainly by decreasing the blood sugar in your blood and bringing it to your muscles. If we had to do a little bit of review of anatomy, your muscles need that sugar to basically grow, function, move, and do its day-to-day activities, right? So we need that something to bring that glucose, that sugar in the blood, to that cell to make it work. So this is our main focus for today, is going to be your pancreas. So let's do a little review on your diabetes. So we have two types of diabetes, and mainly this is going to be called diabetes mellitus, not to be confused with your diabetes insipidus. All right. So diabetes mellitus, this is the sugar diabetes, or what everyone knows as the sugar diabetes. So we have two types. We have a type 1 and a type 2. So the way I want you to kind of remember this is type 1, that's something that someone is born with, right? That's congenital. You cannot change that. Someone's born with that. Type 2, that is the one we develop. That's the one you develop by not exercising, bad dietary habits, right? Sedentary lifestyle, meaning you just don't move at all, right? So you have these two types. Now, what happens with diabetes type 1? There is one key difference I want you to know, and that is insulin. We always go back to insulin. So what does that mean? Diabetes type 1, we have your pancreas right here. With diabetic type 1s, they do not, and I repeat, they do not produce insulin. There's no production at all. That's the problem there, right? There's a dysfunction in what we call beta cells in the pancreas. There's no production of insulin at all. Type 2 diabetes, because of that lack of activity, bad dieting, a little bit of hereditary components right there, over time, our pancreas doesn't function as well as it should, and now we're not producing enough insulin. So big difference there. Type 1 diabetes, no insulin hormone. Type 2 diabetes, not enough insulin hormone, but they're still producing. And knowing basically the fact that one produces and one does not will tailor how you address this patient. So type 1 diabetes, a couple of key things to know is the cells break down protein and fat into energy, right? Because the cells don't have that capability to use that glucose, that sugar in your blood. What in turn is now used? That is going to be your proteins and fats. You can't use the sugar, so it's going to go to the next best thing, protein and fat. Not usually a good thing. We go into a state of acidosis, right? With type 2 diabetes, right, this is something that we develop. So the two different types as well that you're going to notice with the type of patients you're going to get is with type 1, this is going to be the one that are found with your childhood, with your kids. This is when it's usually found. Childhood diabetes first, right? Childhood diabetes is first, so it's 1. Type 2 diabetes comes second, which is something that you develop because of a bad diet, right? So to recap a little importance of why you need to know which produces insulin, which doesn't. So if we take a look at your type 1 versus type 2 diabetes, the treatment option is going to be totally different, all right? So type 1 diabetes, the insulin hormone. Type 1, first diabetes, childhood diabetes, they do not produce insulin. So what do we give? We give insulin, right? We're going to give insulin. So your insulin is usually given on subcutaneously. We're going to talk about that in your medication administration section. Now, when we give insulin, one thing you have to teach your patients are they're going to be on insulin for the rest of their life. They're not going to just magically produce insulin at some point. They will be on it for the rest of their life. Now, I want you to take into consideration your type of patients, right? You're going to get patients that are 10, 8, 12, very young pediatric patients. And communication and education becomes a big key factor to this when you're addressing these patients. Now, let's look at the other end, type 2 diabetes. Type 2 diabetes, second diabetes, something we have developed through diet, exercise, lack of, right? So what do we do for it? Because they are still producing insulin, we are not giving insulin as the first line option. We're going to do the least invasive to most invasive. Least invasive being diet and exercise. That is gold standard number one thing you do for your diabetics type 2. Number 2, if the diet and exercise does not work, we're going to go up the scale there and give what we call oral hypoglycemics. Hypoglycemics meaning lowering blood sugar. Oral meaning oral form. We're going to give these pills that lower the blood sugar. Now, what are they? Metformin is your number one there. Metformin. Now, the thing with metformin is it does not increase insulin. It makes insulin more effective. So we can't give metformin to your type 1s who don't produce insulin in the first place. That's why we have it for your type 2. Now, if the diet exercise doesn't work, if the metformin doesn't work, we're going to give insulin. Then that is your last line there, is giving insulin. Now, the thing with your diabetics type 2, we don't want them to be on insulin for the rest of their life. We don't want them to be on oral hypoglycemics for the rest of their life. We want them to be healthy enough that we can remove the insulin first, remove the metformin, and hopefully just maintain them on diet and exercise, right? Now, we're going to take a look at what we use to diagnose, to distinguish what the doctors use to diagnose type 1 versus type 2, right? The main thing you're going to look at is your blood glucose or your blood sugar. Glucose is the more formal term for it. Now, different texts say different things. You're going to get greater than 110, greater than 115. The importance is to kind of know that range. But your number one, I say number one, your number one determinant of being diagnosed with diabetes is going to be your HbA1c, or for short, A1c. And that level is 6.5 above. That is the level you might want to know for your NCLEX, HESI, ATI. That is the distinguishing factor to make sure to be able to tell if someone has diabetes. And it looks at over the 3 to 6 months of someone's blood sugar control. Not just the current blood sugar, but over that course of time. Now, what do we look at when we're looking about what symptoms are we looking at? Now, one thing you need to know is when someone's symptomatic with hyperglycemia, that's usually because it's in a pretty late stage. If my blood sugar was high today, doesn't mean I'm going to have these symptoms. So these are some signs that you see on your patient that might warrant you to tell your doctor, hey, we may want to check this patient's blood sugar. We may want to get an A1C. I'm seeing these symptoms. So what are we looking at? And I want you to remember this. This is the classic signs. 3 Ps. Polyuria, polydipsia, polyphagia. Now the word poly right there, I want you to know that means many, a lot, excessive, just overall a lot, right? Poly. Now the second word, urea, polyuria, meaning urine. Many, urine, too much urine. Now with polydipsia, poly, a lot, dipsia meaning thirst. Dipsia is thirsty, so you're very thirsty. Polyphagia, that phagia, not to be confused with phagia. Phagia means hungry. Poly meaning many, phagia meaning, poly meaning many, phagia meaning hungry. So you're very hungry. So polyuria, polydipsia, polyphagia. And to make that easier and simplified, I'm peeing a lot, I'm thirsty a lot because I'm peeing a lot, I'm hungry a lot, right? All right, I'm peeing a lot, thirsty a lot, hungry a lot. So those are the main 3 things you want to watch out for high blood sugar. That's what we're looking at there. Now we're going to have a different section to talk about the big differences between hyperglycemia and hypoglycemia on the next segment. So we'll stick to diabetes mainly today. Okay. Now, we can't just stop there, right? People can die from diabetes. People can die from diabetes. So what do we want to take a look at? So we just finished this section on treatment and signs and symptoms. We're going to go through down through each segment right here. All right. So we're going to talk about two different emergency, and I'm going to emphasize this, 2 different emergencies that can stem from type 1 and type 2 diabetes. And I want you to section these in each one. Mostly they're going to present the same, but there's distinguishable factors to it. Number one is your diabetic ketoacidosis, or what's known in the hospital as DKA, right? Now, for your type 2 diabetes, we're going to call it HHNS, and that's your hyperglycemic, hyperosmolar, non-ketotic syndrome. I know that's a mouthful, but the main word I want to emphasize there is non-ketotic. We're going to talk about that too. So let's talk about your DKA. As you can see, it's in your section of type 1 diabetes, and DKA usually happens in your type 1 diabetes. Why is that? Diabetic ketoacidosis, and your word is there, acidosis. Type 1s, right? They burn that protein and fat, and they develop acidosis. That's it, diabetic ketoacidosis. Now, what happens there? It's just an extreme form of that. You're not producing enough insulin, your blood sugar becomes very high, and when we talk about very high, your blood sugar, anything above 240 is high for your type 1s. And what we're doing is we're breaking down protein and fat in a very, very extreme form. So what happens is we build up ketones and we create acidosis. So two words I want you to remember for DKA is ketones and acidosis. So what are we seeing with your patients? When we check their urine, there's going to be ketones and they're acidotic. Blood sugar is going to be high. And one thing you want to watch out for, classic symptom, is their breathing. We look at it as Kussmaul's respirations. They're breathing out CO2 because CO2 is an acid. Another thing we're going to watch out for is, think about your diabetics. They have too much sugar. They're breathing it out. You're going to smell that breath on your patient. It becomes fruity, like they just had a cocktail drink, right? What do we do for DKA patients? Number one is fluids. We want to replace fluids. Number two, we want to replace insulin. And number three, we want to replace electrolytes because they will be losing electrolytes. And we'll discuss that at a further time when your electrolytes. But number one, fluid replacement. We're going to IV fluid, not PO. We're going to give IV fluid. We're going to give IV insulin, and then we're going to replace electrolytes. So DKA is strictly what happens in your type 1s. Now, type 2s, it's pretty much the same. What I want you to get out of your type 2 is there's no ketones, there's no acidosis, okay? No ketones, no acidosis. So what happens in your type 2? Remember your 3Ps? We're just going to take your 3Ps and make it 20 times worse, 30 times worse as you can get. So if you're peeing a lot, you're more dehydrated, and you're excessively thirsty because you're very dehydrated, and you're excessively hungry, right? You're not breaking down that sugar. So what's happening there? Your HHNS, right? So that's the DKA without the ketoacidosis. So no acidosis, right? No ketones, no Kussmaul breathing. All they have is the blood sugar. And usually the blood sugar is higher in this phase. It's a blood sugar greater than 600. So what do? We replace fluids. Now, we can gradually lower insulin. You do not want to rapidly lower insulin, by the way. We can gradually lower insulin, but number one is they're extremely dehydrated. We want to replace the fluids. We want to still give insulin administration, but IV is not required because it's not in an extreme form of DKA. And we also want to correct electrolyte imbalance. So same thing with your DKA, right? Fluid, insulin, electrolytes. Fluid, insulin, electrolytes. I want you to remember that for both. So big difference again with your DKA, HHNS. Your DKA has ketones and acidosis. And then you have Kussmaul's respiration to blow out the acid and a fruity breath. HHNS, same things, but doesn't have the ketones, doesn't have the acidosis, doesn't have the fruity breath. Okay, so those are things you want to be watching out for. And again, for both, main treatment options are fluid, electrolytes, insulin. Okay, so that's it for diabetic type 1 and type 2 segments. On our next segment, we're going to be talking about hyper and hypoglycemic events and how to treat those. So please join me again for our next segment, and I'll see you soon.